Um, any kind of a like scoliotic situation where you've got psoas muscles imbalanced in their pull, that can create torque, and a lot of that will end up in the skull. It'll end up wherever the tissue that's being affected by it starts to get irritated and inflamed. That's usually where it shows up. And so often the skull. The other thing that will cause all kinds of cranials, including this one, especially parietal descent, is an imbalance in the TMJ muscles. So we're going to get into TMJ, I think, next session or two. What is this, session 3? Yeah, session 3. So we're going to teach TMJ in session 1. It's so important, but so anyway, these are when you see category 1, like I don't know, about half of us in here had the category 1s. You'll often see temporal bulge. So the temporal bulge is basically a bulge, kind of a out bulging of the parietal bone and the temporal bone. Now, of course, there's other things involved, but that's the main thing that will become obvious. The kind of unique way to screen for this, or what often presents with this, is a bilaterally weak PMC. And if you have if you're testing PMC and test them bilaterally, which we often do for ocular lock, a lot of good reasons to use a bilateral PMC test. If they're weak in the clear, that's a good indication you've got a temporal bulge. And when you have a temporal bulge, you also will have often stomach issues. You'll often have hypochlorhydria. You'll have a sort of a decreased ability to produce hydrochloric acid in the stomach, which, of course, is another problem. So some would say that the cranial torque causes the digestive disturbance. You could also look at it from the perspective of the digestive disturbance is probably part of another process, which will cause muscle imbalance, which results in torque. Lots of ways to look at it. But nonetheless, you'll see these come together. Like, it's amazing how often you'll see them together. So the other unique thing about the temporal bulge is it will strengthen the bilateral PMC weakness will strengthen to a half breath in, not a full breath, not a forced full breath like a stenobasis, but a half breath in. Does anyone in here have any issues with their stomach? Would you be comfortable sharing what kind of problems you have?
Yes, it's been a chronic issue I've had for about 3 years. Like that for what's going on. I was actually in DSDL and I realized that my stomach was up in my diaphragm should pull down, but still some issues I have overgrowth.
When you had the procedure done, did it help?
It helped with pain.
For a while?
For about a few days.
Okay. Not you, but for class. It's a collective here. Yeah. Okay, so let's just take have you had much cranial work done?
No.
Okay. So, remind me your first name.
Cool.
So nothing earth-shaking here. I mean, maybe a little bit of something going on there. Did you have a cat one?
I didn't have anything.
You didn't have anything. That's all right. So, I mean, nothing remarkable in your posture. If anything, maybe your shoulders are tight, but you're a student too, so your upper traps are open. Let's just do a quick. Okay, so those are strong and clear. Put your name picture. That's do you guys see that at all? slow. Close. See that? That look normal? Yeah, yeah. It's pretty normal, except that he goes a little to the side, and he also, as he opens, kind of draws back. That's a muscle imbalance going on with the PMJ. So any tenors along here?
On the right side.
The right side. So he's a good candidate for this. He's got several things that would be often seen, but you didn't have a captain. Push in. See, those are strong in the clear. Wouldn't breathe out. Now relax your jaw. Relax your jaw. So he's guarding your jaw. Is probably you didn't have any. They didn't find anything. But right now, he's got TMJ stuff, which I don't want to get into this weekend because I can go down that rabbit hole really. But I want you to relax the jaw and just breathe normally. So that's now take a half breath in. Full breath in. Half breath out. Full breath out. Half breath in. One more. Breath in. Now everything's you're going to be one of those, okay? I don't need to. Relax the jaw. Breathe in through the nose. Hold the breath. Out through the nose. Jaw. Just weaken half breath in. Yeah, so he's got a bilateral weakness, but it's not necessarily coming from radius. Can you touch right here? Actually, let's make sure we got it. So I'm coming off a weak muscle, clear, and going to strong because that's a stomach-related muscle. EMC is stomach-related. PMS is liver-related. So that's interesting. So I'm right here on what's called Rittler's point, which is right on the edge. Anybody not familiar with Rittler's point? It's kind of a naturopathic thing. Rittler, his name was Rittler, and I think he was a naturopath, but he, there's a tender spot on the left rib cage that is indicative of hypophagia or some kind of stomach acid imbalance. It's, I think, more predictable even than the Chapman reflex, which is at the between the fifth, sixth rib. See, that turns it on too. Okay, so he strengthens to Rittler's and he strengthens to the Chapman. And if I challenge his stomach up, he strengthens to that too. Okay, if I pull that down again. So he's got kind of what appears to be, because you shared that you had it pulled down. He has sort of chronic esophageal shortening, causing the stomach jamming. Call it hiatal hernia, but I won't call him that unless I have X-ray verification. Because a hiatal hernia is a pretty serious condition. In AK, they throw around, oh, he's got a hiatal hernia. What it really means most of the time is that their stomach is jammed up against their diaphragm, and it's causing problems. Now, we're going to learn this, but not this session. You guys want to come down, and I want you to see this, because we'll go through it in great detail. I'm gonna get on this side because this is kind of my strong suit. I hope you guys are different holes too, but, deep in the cliff. Now, if I was smart, I would go to find another, I'd find another not manipulated muscle that's strong and go back again and have like a positive TL with strong that. So, um, so the in my chart, when I chart this, I chart it as esophageal. I can just see somebody someday, you know, doctor, you said that. So that's positive, right? Challenge. How do we know? Static challenge. So what I do is I get up underneath the rib cage and I see how much of the stomach I can feel. And realizing that the liver has a piece that comes in. Pancreas is liver. All kinds of stuff. So for me to get at the top of the stomach, I've got to push my breathe in, and then I get as far up as I can, and then I have him breathe in. That flattens the diaphragm, so he's pushing the stomach. I feel it right down into my. And then just as he lets his breath off, I just roll. Now, let's see, that already. That's how found this is. Those were weak and clear and strengthened. And we needed that. Chapman, John, he's a quick judge. He doesn't want to be weak. Now I'll go back and I'll challenge body color. That was challenging the esophageal. Now I do these all the time on patients. I find them all the time. And now let's have you back to bilateral. Still weak bilateral. Half breath in. So he has it, but it was being sort of superseded by an issue, and they are related. Now we don't know which side is comparable. There's a couple ways we can find out. One is we can TL. The other way is we can challenge. We can challenge both sides. It's easier to TL. So we all know where suture is. Temporal. So put flat fingers. And over that suture. Now see, this muscle is strong and clear now, but I'll use it. So that definitely. Now breathe in. Difference, breathe out. Half breath in. Half breath. Half breath will verify. That's the key. Half breath, half breath in. So, we know it's on that side. How do we fix it? Well, this is a perfect example. So, I think, did I ask if there's 10? That's where the parietal descent side is. So, but that's where you'll find the TL, the upper picture there. And the tendon is often right after that. So the challenge is I'm going to be challenging between his right where his frontal bone meets the temporal bone, and right behind the mastoid, sort of at the mastoid occipital junction. And my vector is going to be just like those colored things. I'm going to start out just kind of straight together, and then I'm going to look for extra video to use from the cable. That way. These are weak bilateral, yeah. So I can use the one because it's strong and clear. Your arm just like that. Then so that's pretty good. Now I'm gonna vary my vector. It's about the same. To vary my vector the other. Okay, that's the vector. So my vector is a little bit off. So I'm going to do the correction. And actually, these are pretty easy. You can let your legs relax. So my one contact is going to be behind this mastoid. And I usually use the heel of my hand because it's fingers. And my other contact is here. In this position, I kind of have to trying to get, there we go. The vector closer to what. You can feel the flex. Okay. Now, again. Now, some of them are actually visibly apparent. His, not so much. First of all, let's see if we that a half breath out, full breath out. No, that brought that way. Now, do we still have the other part of the center? Let's have to go to the side. Half breath in. Full breath in. Yeah, so that's it. So the parietal descent, I have pictures of here. So the temporal bulge we correct this way. Down correction, 3, 4, 5 breaths or so. Temporal bulge, I mean the parietal descent, is going to be over here. And the parietal bone, the idea is the parietal bone is kind of descending down onto the temporal. So I'm just basically going to lift this on an exhale. This one on inhale. Cross my thumbs over the cruciate, sagittal suture. What I don't want to do is I don't want to pull his parietal bone up and then cause a jamming in his sagittal suture. Remember session 1, I think? We learned sagittal suture and the abdominal, rectus abdominis thing. Okay, so I cross my thumbs like this so that I'm on both sides of this sagittal suture, stabilizing over here. This right here, I'm going to be lifting up. I want you to breathe in and breathe out. On the exhale, I'm lifting up. Like I'm rocking the top half of his head over. Now, his temporalis is tight. That's why his jaw opens. So, he needs some TMJ too, but that may be part of the dural torque thing. Nice to know what you were like before a few months ago when you.
That's been years.
Oh, you've been having,
Yeah,
oh, I see, for years.
Yeah.
Not that old.
A lot of antibiotics.
So let's just see.
breath in, full breath in, half breath out. So be strong all the way through. So right now it is a very relaxed position. And then balance down. But I'm just going to stimulate his Chapman. Have you tried hyperbaric acid or any of those kind of classes? Any of that?
Not recently, years ago I did.
Somebody tossed me one out of one of the test kits. There's Phoenix has HCl plus and hydrozyme. The standard one has Zypan. Yeah. For the rivals. Yeah, sure. But yeah, let's see the. The temporal bulge will strengthen on half.
And the other one, the parietal.
The parietal is saying,
Exhale.
yeah, it'll strengthen on half. I don't usually worry about that. I mean, remember that for your test. I don't usually worry about. I fix the temporal bulge and then I just fix it. So we're just going off this chapter. That's a really good. I'm going to do these blind. Totally woo-woo. Don't have a magnet. Yeah, so one of them tests. Pretty obvious. And I don't know what it is. HCl plus. Which is the stronger. Hydrozyme is, they're not too bad. HCl, I think this is like with 8 hydrozyme. That could be. Now, if I do any kind of nutritional thing, ever, not only do I see it made the change, positive change, strengthening, I'll have to whip that. I'll test it strong. I think it's also sure it doesn't. Sometimes I'll get stuff that seems to strengthen, and we can get away from whatever reflex are challenging, just test it in the clear. There's something in it that seems to be. That would be worth testing. Because and that goes like you're kind of textbook for but why would we not be producing enough hydrogen gas? One good reason.
Zinc.
Zinc's one good reason. Because it's zinc dependent. But what's another really good reason?
Sympathetic.
Yeah. From sympathetic drive. Going to sympathetic drive and production of hydrochloric acid takes a backseat. It's just not that important. Body, and sometimes it gets into that pattern and does it help to get really hungry?
Yeah, but I don't have appetite at all. So I have to force me breakfast and lunch.
Is it not more testiness and emotions?
Oh, if you were testing. Theirs is adrenals. There's go to kidney, Atman, adrenal, kidney. Go to ICV. Hopefully we'll get to it. Thank you for that. So HCl plus. I would start with like one per meal
Yeah.
for a few days, and then if you don't have any heartburn or tingling, then kind of move up to 2 per meal. And you move down on too long.
Yeah.
What it does is, you have to have acid to absorb zinc, or magnesium, or iron, or anything else. All minerals need an acidic environment to iron.
So we want to start with these. And break it down. Acid.
Yeah, I mean, you could say, oh, put him on, like, here's a gentleman who, they decide they're gonna go paleo. And these patients, I've gone paleo. And, carnivore, I've gone carnivore. Like, YouTube, whatever. And so, but their HCl production is not anywhere near up to snuff. Now they're all of a sudden putting this really dense protein in there. And, it's, sometimes they really, what's strange is a lot of times people do really well on this diet until they don't at some point. But, yeah, so that would be, if you can't break down your minerals, or if you can't ionize your minerals or break down proteins, 80% of protein digestion occurs in the stomach. So if you're not getting it done there, then you're going to have a lot of poorly digested protein sludging its way through the remaining 23 feet or so. And so, yeah, I would. And of course, you probably already are, but really diligent about mixing, starches and protein, and you're chewing and whatever. But, yeah, there's and probably an emotional issue or something.
Yeah, I've been working on it.
Yeah.
Quite a bit.
There's probably that too. But yeah, the sympathetic drive thing. Do you have kids?
No. Just a student.
Yeah. I know sometimes, we got people who have kids, right? Grandkids, right? I mean, kids, we can talk about, Dean and I can talk about what kids do to your life. Good and bad. Good and bad. So anyway, so that's temporal bulge and parietal descent. That was a great example of how they will come in pairs, and they come along a lot of times with this stomach issue. And let me just test one more. Let's just see if you have bilateral hands over the SI. Yeah. So not really. He's good. Good. One hand. The other hand. The sacral wobble. No, so you don't have it, but that's good. Take your hand, and I want you to touch, I want you to feel, so that you're touching the mastoid, the occiput, and see, so like here. I want you to stand. I want you to touch right over your sacrum. Okay, that's good.
Check his TMJ.
You're different. Open your jaw. Yeah, you're still going back. That's actually much straighter. Yeah, actually, anything you might be eating right over there. I am. Okay, so take your hand and open it. This is his masseter. Okay. So he has, and this was the temporal, no, this was probably something. Yeah. So he has a hypertonic temporalis. And it was yanking his jaw a little bit to the left, and now it's actually changed because he has a creative. Now you're actually pretty straight. If anything, you might be going that way. So you'd be a perfect candidate for Thanks for bringing that in, of course. Excellent. Excellent. So, the Terion right here, Terion, and then first the Asterion. Areas that we so bilateral, remember this for your exam. Bilaterally weak PMCs in the clear, strengthening to a half breath in. Make a note, mental note of that. Hypofluorhydria, C1, you see C1 with all kinds of things. But Cat1 and the temporal bulge, they go hand in hand. As does the sphenobasalar with category 2, like last session. Often you'll see a sphenobasalar cat 2. Bridal bone descends. A weak muscle strengthens when a half breath is let out, starting from a full breath, which we checked. Tenderness, TL. Oh, that's right. With bridal ascent, you use a two-handed TL. We skipped that. We just did. We went straight through it. Just went straight through it. Just the one hand. There's the challenge. There's the correction. And you do it on exhale. So same as temporal bulge. Think temporal bulge and bridal ascent. And an N. Two peas in the pot. So once again, dural torque. When you see anything TMJ, anything cranial, especially this kind of cranial, think dural torque. Think Cat1. Think stride length. Think the gait testing stuff we did last session, where you put people in gait and test for the appropriate inhibitory muscle, the appropriate muscles inhibiting sacral wobble. We covered this. Anybody have any questions on sacral wobble before we leave? Let it soak in. We had the one expiration one, which was fun. Anyway, always the rebound respiratory correction system is the golden rule. I don't know why I have two slides saying the same thing. So I plan to occipital counter. I'm going to run through this real quick. We won't workshop this yet because get to something else. This is like sacral wall. It's like in the neck. And it's basically, basically what it is an occipital fixation. The occiput and C1 their relationship is skewed. They're not in a nice skull. The occiput should be resting nice and even on the atlas. And what will happen is you'll end up with sort of a jammed, joint between the atlas and the occiput, because the occiput sits in the atlas condyles or facets kind of like a bowl. Anyway, don't worry about this. I tried that on Cole. Basically, you do a TL where you're covering the mastoid, the occiput, and C1. And it can be just part of a screen when you're screening for atlas or things like that. If you find ocular lock, eyes up and to the right or up and to the left, that indicates occiput. Remember from last session. That you can also do a quick TL for this because it might involve this. There's a lot of overlap in how people have come to name this function in these areas. So anyway, we won't get bogged down. This is another, the same with this, we tested him for, this is where you test the sacrum and then you traction down. And this could be that the dura is kind of stuck. It's called meningeal release technique. We'll mire down to this right now, but these are like sacral wobble. These are kind of finishing techniques if you've done all the big stuff. And a lot of times you'll find, and we don't have one anymore. We used to have a rolling tape measure. It's really handy. You can tape, run a tape measure on a patient from, and then have them stand up. And if the dural torque will cause them to shorten. There shouldn't be more than, I think it was Dr. Goodhart, should be 14 millimeters or less, which is very much. Not that much. If it's more than that, then that's a good indication that you've got dural torque. My anatopical short leg patients are sometimes the ones that give me most challenge because they're naturally always in a state of dural to some degree. And their bodies, get pretty good at compensating, but they're always on the edge of torquing out. And I'm not a heel lift fan. I got a little box of heel lifts in my office somewhere. I'm not even sure where they are right now. I get a little frustrated sometimes with some of my colleagues that throw heel lifts on people because they can't seem to fix their pelvis or their stuff. Oh, we got a short leg, we'll put a heel lift in it. And honestly, I unless they have a significant leg length, we're talking centimeter plus, centimeter and a half. And usually that's from trauma. Maybe they had hip dysplasia or maybe a bad fracture that resulted. And these people a lot of times they really do need it. But the heel lift, I much prefer to get a shoe lift. So anyway, this you can go back to this. This is another little finishing technique. This is where I wanted to get to. So you guys are learning in your phys med classes. I'm sure you're learning sensations. Use motion palpation to determine where you're going to adjust. I assume. What are they teaching you? Those of you who have been through all that.
It's palpation.
Palpation. So palpation of the vertebrae, the muscles, and then you do your corrections based on.
Sorry, we do like differentiation.
So you're familiar with the concept of fixation. Do they ever use the term subluxation?
No, not really.
They don't. They're different. Yeah, they probably don't.
We
You can't
just
say
use
subluxation.
function. It's typically the word we
You,
use.
you own subluxation.
What's that?
You guys own that one.
We do, yeah. But even there's a lot in my profession who have a hard time with it. But subluxations are a real thing, but they're different than fixations. They behave differently. They affect the nervous system differently. You adjust them differently. I wasn't really taught classes in chiropractic. I had to learn all that after I got out of Western States. They watched a lot of old-timey stuff out of our. So, but there's some real value in the old-timey stuff. It was brilliant. Onstead techniques, some of these things, they're quite amazing. They didn't have the neurological narratives to explain what they were doing. But what they were doing worked really well. It still works really well. So vertebral fixation is 3 or more. Basically, it's you got a middle one that's fixated on the one above and one below. You can have 2 vertebrae fixations, but that's more often subluxation. And it involves the intrinsic muscles, rotatories, semispinalis, those little tiny muscles that weave their way through the spine, whose job it is to coordinate and support the fine movements of the vertebrae, individual movements. That's where the rubber meets the road when we're talking about spinal. Talking about adjusting, that's what we're affecting. Little intrinsic muscles, the ones that get out of balance, they get shortened, get fibrous. And then the capsules start to thicken around the facets, and that's what results in degeneration in the spine. And so those are the muscles that we're looking at. But Dr. Leaf used to say that he believed that fixations were the nervous system's attempt to control neural torque. That the brain is tightening intrinsic muscles here and there, trying to control neural torque. That was his thing. So you can clear fixations all the time. A lot of you have done it, and then they keep coming back. And SI fixations is a good example. I mean, they're not too hard to adjust. That's one of the first things you learn to adjust. And but they keep coming back. So when they keep coming back, what's the deal? Upper cervical fixation, pretty common. They're pretty easy to fix, but they keep coming back. So there's something else going on. What's interesting is fixations tend to display bilateral, except for a couple of them, they tend to display bilateral muscle movements. So here's the list of what, we'll keep this up there in the workshop. These are classics, and if you look for these, you'll find them every day. I don't really look for the toe flexor thing so often, but occiput, bilateral psoas, and upper cervical, I find that every day on somebody. And of course, what you have to do, you have to, as you're examining the patient, for whatever reason you've gone in there, you've got to keep in mind what you're finding weak and what you're finding strong. Oh, both glute max are weak. First thing I think of is upper cervical. Both psoas are weak. I think of two things. The first thing I think is have them take a deep breath in to see if it's cranial, sacral, or diaphragmatic. Suggest what psoas attack. Or is it occiput? A lot of times it's jammed, especially the inferior occiput, will result in bilateral psoas. So these are really solid things you can count on. If you find it, you look for it. 80% of the time, you'll look for it. That's what they'll have. Bilateral deltoid is going to be CT junction fixation. On and on it goes. Thoracolumbar. Some of the muscles we're learning this session have to do with lower tract, because we haven't learned that one yet, and teres minor, and popliteus. These are all teres major, popliteus, neck extensors we haven't done yet. We've done neck flexors. So here's another chart. You can print this, and this is actually a better chart because here it shows on the very bottom here the limbic fixation, which is particularly interesting. It will cause all the muscles on one side of the ankle to be. The lower limbic is L1 T12 rib, and it will cause spinal extensors. So we'll find probably all of these in here. So how do you find a fixation? Well, first you suspect that you have one. Have the patient do a two-handed TL. Say, for example, psoas, both psoas muscles are weak. Patient does a two-handed TL right at the occiput. You have them move the head around. Remember this for your test. A fixation will therapy localize only in conjunction with movement. It will therapy localize other times too. But for the purpose of your test, that's how you determine. Subluxation will therapy localize with no movement, bang, will make you globally weak. Fixation, a lot of times you have to induce motion.
So if you come from a weak muscle like bilateral psoas weakness, use motion and it turns on, then you can go to a non-related muscle, strong and clear, and do the same thing and see if you can reproduce it. That's really confirmed that you do have a fixation. Once you have a fixation, or once you determine you do, how do you determine how to adjust it? Well, you move the spinous, like the way you guys learned how to palpate. Move the spinous one way, then the other way, and see which side feels easier. One side will go kind of easy, the side goes harder. The side that it goes harder, you then go out to the TP, and you spring the TP, and you see which one is feels more stuck. Is it the one that's presumably posterior on that side because the spinous won't go very well that way, or is it the one? Is it stuck anterior or is it stuck posterior? That's where you're going to be adjusting. Is that the facet? Using the TPs to affect the facet. So spring, and then you go to the right over the sets. Actually, I go out. If you're facet TP, right on the edge of it, I kind of use the TP to get some leverage. And then if the presumably posterior facet is more stuck, the anterior one, to adjust the top vertebrae of the complex off of the one. Go to the bottom of the complex, usually it's like 3 vertebrae on the other side, and I'll show you how to do this. And then you adjust the top vertebrae off of the middle. If it's the reverse, if it's stuck anterior, you go to the bottom vertebrae of the complex. You adjust it off of the one. You don't want to put pressure against a facet that's already anterior. So you make it worse. Trust me, I know. Yeah. So in this case, you would adjust. Now, you want to do the adjustment on a breath in. Honestly, I do it on. I kind of go with where I can feel the spine releasing, but the correct answer is you do it on a breath in. And Dr. Francis, he was really big on this. He adjusted all of his fixations on a breath in, which is interesting. You know, a lot of times in school we were taught to adjust on a breath out. So octacosanol, wheat germ oil, is the official nutritional support for returning fixations. Limbic fixation is kind of special because it involves C7, T1, and vertebrae. And it'll be on one side, and it will cause the ankle muscles on that side. I see these pretty often. If you look for these, you'll find them. They can be really life-changing for me. The lower limbic is kind of a thoracolumbar issue. That could be a long-standing psoas imbalance, all kinds of things, injury to that area. So anyway, this is how you TL for the limbic, bilateral TL, and then you turn the head right. Motion. We're going to, we haven't learned these muscles yet, but some of you know. And these muscles will all go weak on one side. It's a trick. When I first learned this, I've been in practice for quite a few years, and I was just amazed. And then when I started looking for it, finding it all the time. Anybody here? You guys are all fine today, right? Anybody here have chronic? Somebody had a chronic pain. You had a chronic pain. What's that?
I'm healed now.
You're healed. Do you have any issues up in your? Okay. Could we check you for limbic? Dr. Goodhart called it a limbic fixation. There's a whole story behind it, but it had to do with trauma and fight or flight stuff. Okay, so let's have you just lay it down. So because I want to find somebody with this, let me, which ankle? And you sprained it a few times?
I got rolled both of them.
No, you were the one that had the.
Yeah, you just fixed it. Yeah, you just fixed your compaction.
That's right, you were that was you. Okay, so that's a glute knee. I want to just see what we got to work with here. Yeah. Okay, so those are great. Breathe in, hold your breath, push out. So she strengthens on in breath and breathe in. Okay, so, well, let's see the TLs. I want you to put one hand, I want you to actually put one hand here. Now, so let's go strong. Yeah. So that TL is without, so, would you then touch the C7? One hand and your other. Now move your. Now, touch the C7 with that hand. You see motion. There. So it's on the right side. That's where your ankle was. Let's see if what I fixed stays fixed. So I know we haven't gone through these yet, but this is tib posterior, down and in all the way there. And you kind of scoop up this way. And that's, yeah, it's weak. Let's try it on this side. Now, if she was weak on both sides, I'd start checking other adrenal-related muscles, because these are adrenal-related muscles. But it's just on this side, so. Curl the toes down. Tib anterior, right here. Good. And that one's good. Push up and out, tib, or peroneus tertius. So much, down and out. And hold. And peroneus. So the tib anterior, curl the toes down, actually isn't strong. If I let you flare your toes up, yes, yeah, miss it. Keep your toes down. We'll learn all these, but the tib anterior, we end up, yeah, there it is. Okay, so touch your C7 with your left hand. First rib with your right. Move your neck around. Now bring this down again. This was the weakest one, so it was it's easiest to see. That turned back on. Push out. Good. And up and in. Curl the toes down. Okay, so you have a limbic fixation, and it's affecting your right. Now, who knows? Maybe walking around with that ankle, maybe it's what created the door. So stay there for a second. Relax. Let that sink in. That new news. So we challenge it. Now, we know it's there on the right side, but I don't know how I'm going to adjust it. I kind of do, but I'm going to challenge it away, and usually it needs to be accelerated. So, so I can. Did you have a cat one? So is that? So there's her first rib. There's her C7. So I'm going to pull. Actually, let me get it strong first. So I'm going to pull apart.
And if I was gonna do these respiratorily, I'd have her breathe in. Challenge this way. Challenge. So her first rib needs to be kind of moved this way. C7 needs to be moved, yeah. So C7 needs to move this way, and this first rib needs to move this way. I'm just going to adjust it with her permission. Is that okay? So you can do respiratory. If I was going to do respiratory, I would go back to the challenge. Breathe in. Breathe out. So she strengthens on her exhale. Breathe out. So I would do it on exhale. I would do her first rib. C7. Challenge it that way. Okay, doesn't. So breathe in. So the C7 I would do on inhale, and the first rib I would do on exhale. If I was going to do it respiratory, but I'm just going to do just a very gentle, kind of normal correction. I'm going to take her first rib and just give it a little nudge. And I'm going to take her C7. I'm going to reach underneath her neck. Get the Vancouver girl. Yeah, right. And I'm going to pull her C7 this way. There we go. We got little cracks. Okay. Now, first, let's see if it TLs. Turn your head to the right. Oh, around. Okay, now take your hands away. Let's see if these muscles tuned up. They thought we had them tuned up before. Push. Okay, that's really good. Down and in. Okay, very good. Okay, down and out. Up and out. Yeah. Yeah. So that worked. That worked as prescribed. That's upper limb. You can imagine how an athlete or someone who's been in some kind of wreck or accident, where there's like, I've had people with whiplash injuries, where they were turned when they got hit. These things for years until somebody finds them and treats them. They just get set in there. Football players, man, I mean, they get hit in all different ways, and it will cause trauma to those intrinsic muscles. There's several things going on. When you breathe in, you're increasing intrathecal pressure. And just like, and that amps up the motor signals. It kind of suppresses the inhibitory signals and amps up the motor. That's one reason. So the idea is it facilitates the correction. I think, beyond that, is that tape running? I think beyond that, it has more to do with, or as much to do with, as intrathecal pressure has a lot to do with. When we breathe in, when you've done energy work, or some of you I know have done Reiki, and when you get really tuned in, you can feel the energy shift as you breathe in and breathe out. You're able to tune into it. Every time you breathe in, there's a shift energetically. So I think there's something to that too. I think in the intrathecal pressure amps up the hardwired part of the nervous system, and the breath and its effect on the chi amps up the breathing system. That's the best I got. But it's so obvious that it affects. So upper limb. Now just screen for this. Just have the patient do this, turn left, turn right. It takes that long testing is strong. You can screen for this when you're doing things, and then you have it. Then go to C7, first rib on each side, determine which side it is, then and then you challenge it. Dynamic challenge. First rib and the C7, and you like with we would have adjusted the first rib on exhale, the way it tested, and the C7 tested. If I would have done respired, I would just get it. First time. Lower limbic, same thing. It's a two-handed TL, induced motion, and then you do I'll just do a basic thoracolumbar adjustment. You do it respiratorily or dynamic. Okay. Does anybody want to see the lower limbic? See if it's.
Their whole has it. I mean, or I have one.
That one? Lower limbic. Do you have an upper limb? Do we check an upper limb? After your bike thing?
After my face thing?
Your bike, can we check you? Just see if we have it. Now, the other fixations we're gonna workshop all those, but they're not as complicated as the limbic. The limbic is so profound. Yeah, you can see. And you can test for limbic, seated, standing. Oh, yes.
Not from that.
I'm ready to do that. So on the left, TLC7.
Sure, I went
Yeah, left straight. So it's on the left side. Now, and this is easier to do with the person seated. So it's the left side. So let's see if we can get a good. Okay. So I'm just going to challenge her first rib. Challenge 7. So breathe in. First C7 is interesting. Don't be afraid to do it 2 or 3 times, 6 times. I mean, if you know it's there, a lot of times we know it's there, but
So you just adjust.
what's that?
You just fix both my shoulders.
Oh, I did.
I felt
Oh, good. So we can do the see if this will respond to respire. Yeah. So I'll do both of them. Is that okay? But before we do that, let's see what our ankle muscles are doing. I mean, do all the muscle, so the ankle have to go weak with the lifting? Probably not, but it's very, very common. So I'll just start going around. Is it on? Oops, this side. Okay, so, yeah, these are fine. So, yeah, okay. Perfect. Oh, yeah. Yeah, okay. Now TL, your C7 and your first grip on that. Down and in. Okay, up and in. Up and out. Down and out. Down and out. There. Move your neck a little bit. Yeah. So, big time. Thanks for correcting. I'm going to use respiratory. They're both in breath. And her C7, it didn't challenge this way. It challenged this way. And so I'm going to take it whatever direction it challenged. So I'm going to get a hold of her C6 and I'm going to pull C6 up off C7 and breathe in. Let it go. And I'm doing traction too. Breathe in. So, there we go. Give me two more just like that. Do that a little time. Now this one here, traction. Get one more. Now, the proof will be in the pudding. Down and in. Up and in. Up and out. And down and out. Okay. Now, TL at the end is to be really down and in. Down and in. I'll move your neck. Use some motion. No, I don't think we got it. I think we need to. Just gonna give you a little. Strong there. Yeah, your neck. Down, down, down. Oh, that's pretty good. Down now. Up and out. Yes. Yeah. Oh, yes. So we'll check the lower lip. So T12. We had a long one. So T12. Sorry, L1 and T12. Yes, spinous of L1 and rib T12. Now,
Sorry, I was pulling it apart. I just
oh, no,
touching,
yeah,
just TL.
Just TL, yeah. That's positive TL. Look at it. I think you got it. Now, take one hand away, just do one thing. So there's a subluxation.
Well, first one was L1.
So doesn't. Yeah, you're stuck. So that's not a fixation per se, it's like a subluxation. Uh, We're going to adjust that. Lay on this side, please. I'm gonna do a side posture for a high lumbar. This is, I remember that, you told me that every time, and you're right. You're right. So to get high up in the lumbars, you need to get flexion. You have to kind of open up. So I'm putting pressure this way. Now, be careful with the ribs. I'm really putting her ribs in quite a torque. So I'm pulling down on this spinous. There we go. With people who are really flexible or have really stringy tissues, you got to take it other way. Now, you can't see what I'm doing, but I'm pushing once again the upper body up. And I'm just guiding. Oop. Did I? Oops. Yeah. Okay, cool. Now. So there's no TL. And now we just kind of move around. Now TL and move around. Oh, now it's a fixation. Okay, lean. Sorry, I don't want to stop. That is, yeah. I'm going to adjust it some. And adjust. And taking a breath. And we'll way down under. There.
Oh, yeah,
That's all.
that was good.
That was good. Now sit up, please. This last time, until she moved. Good. Happy with that.
To adjust that underneath.
I was pulling 212 up off. And then we adjusted L1 side posture.
I thought you like lowered to 100 instead of up.
The first one I was spinous. Spinous this way.
For the fixing.
Second.
Oh, from the top.
Yeah, yes, we lifted it off. Thank you.
Oh, yeah.
So she had an upper and a lower. And that's, so, the, time is it? 2:30? So, we can dive right into ICB and then workshop ICB. Or we can workshop fixations and then go into ICB. What do you guys feel? I feel like moving? I like doing some stuff, yeah. Why don't we workshop fixations? Just go with, excuse me, go with the ones on, I'll put the slide back up there. Just do the bilateral test that would be associated with fixations. Don't chase off into any rabbit holes. So everybody can experience the bilateral thing and see if they can find, I mean, you'll find fixations. But we'll just do that and then I want to get into ICD. So that's going to be That's gonna be big change. This is big change. Yes.
Can you go over how to test the muscles that we're about to test? Because I don't know if I remember.
Dang, that's a good point. We haven't introduced some of these, have we? We have to do that first. Let's do that first. Okay. So, can somebody put the group that is the muscle group for me? Or how do I access?
I can do it.
Alex, you're sitting.
So these are the muscles, okay, so these are all the new muscles. And I would like to just introduce them, and then we'll go through the slides later. But if we go kind of summarize, middle trap and lower trap, part of the trap trio, are related to fixations. Bilateral lower trapezius will be thoracolumbar fixation. Serratus is not a fixation related muscle necessarily. It's a very important shoulder stabilizer. And I consider it right up there with the psoas, as far as big tendon muscles that we function properly. Adductors, same thing, not associated with fixations. Neck extensors are related to fixations. Straight neck extension is related to a lumbar fixation. Right and left is related to iliac. And popliteus is bilateral muscle that's related to mid-cervical fixation. It can also be related to both knees, too. And teres major is related to a lumbosacral fixation. So here's the upper trap. You guys remember the upper trap, right? Anybody want to know about the upper trap? I've forgotten I left it in here with the lower trap. Any questions on the upper trap? Remember the upper trap is related to the eye and the ear, and it's on the kidney ring. It's kind of an odd one that way. Remember, it has dual cranial and spinal innervation, like the SCM. Remember that about the upper trap. We'll trap Chapman. Stress receptors are connected to the upper trap. Nutrition for upper trap. Vitamin A, also think vitamin A. That's for your. Here's middle and low. So middle rises from C6 all the way down to T3, and then T3 down to T12 for the lower. They're the same kind of muscle. It's just that they have different fiber change. So we treat them like two muscles. Goes into the acromion, spine of the scapula. The lower inserts into along the medial aspect of the scapula. It's the most superficial muscle in the back. So basically, they retract the scapula, and then they're involved in rotation of the scapula, more stabilization than anything. They affect all kinds of things. They have a huge, broad contact area, and you'll find trigger points in them. Often these are a source of problems that get overlooked. These outer superficial muscles. So if I was standing here like this, like that, you say, well, your upper trap is high. Okay. I stand here like this, and I was like this. Well, that could be a hypertonic middle trap. Or I can have rounded shoulders. A lot of times the shoulders are rounded, both middle and lower traps are hypotonic. Slouch position. Traps. The way we test the lower trap is the arm is like this, the head is turned towards the arm, and the test is kind of this way. So the muscle does this, you're trying to test it. Now there's all kinds of things you're testing through, so you have to be aware that maybe it is the shoulder joint that's moving, the other muscles. The tricky middle trap, patient's prone, they're looking towards it, and it's really hard. It's really hard to hold that. It doesn't. You won't need much pressure. You'll find these weak all the time. That'll be related to a thoracic reason, as will a teres minor, or teres major. So anyway, you can test. Dr. Mike's testing it seated. You can test it in any direction. The hardest it is to get a strong one is with the patient prone, because there's already a certain amount of relaxation that's going on in extensor muscles. So it's really best if you're going to do it prone to have the patient kind of activate their muscles a little bit, and having them turn their head helps with that. Let me have somebody come up here with, just so I can demonstrate the test in the middle of the liver. I'll have you stand first. You can actually do this. So, okay, so if I was going to do her middle, I would have her do that and have that way. I'm going to stabilize her over here best I can. Hold there. That's pretty good. And same over here. Over there. That's pretty good. Now, for her lower trap, she's kind of here. I want to make sure I'm kind of aware of the fibers run here. Comes that way. She turns and looks this way. I'm going to push this way. That was what we just worked on. Now that one's better, so that's not necessarily a bilateral. Oh, that was actually pretty good. So I would go down here and, so I'm just curious, I'm going to spindle it up to see if it's capable. And it is. The spindle's right up. So there's something else going on. Who knows? Maybe we still got more work to do. There could be a leg thing. Oh, that's right. We just. So anyway, yeah. Thanks. So let me lay face down. Is this me? Yes. All right. Oh, I'm gonna do it. Yeah. So yeah, like that middle trap. See, that's hard. It's harder to do down here, right? And up our lower trap. That was good. Yeah, it was easy. Yeah.
But it's hard.
Well, here, don't go.
Oh.
Yeah.
That was strong.
That's weak.
Well, it was strong.
Oh, okay. So that's interesting. Okay, so when she lays down, she's different. So yeah, that's gonna be. There's something else going on there. Probably. I mean, in addition.
Yeah.
So that's middle and lower. You want to just stay up there. So that the Chapman reflexes are going to be the same as for the lat. They're on the spleen meridian. They're innervated by mostly neck and a little bit thoracic. So the Chapman reflexes are only on the left, seventh intercostal, like the lat. There's the vascular reflex, it's just above the lambda. Thrusters. So interesting, that's right near where you would TL or find tenderness with a temporal bulb. Nutrition for middle, it's mostly anything, think anything mute. Mute related. Anything that helps with. So vitamin C, of course, these are standard process products. So those are the things you would start testing. Serratus anterior, could you please stand? So I don't know, this is the muscle here. I used this picture because I thought it gave a pretty good idea of the extensiveness of this muscle. So this muscle comes off the scapula and then it basically sends fingers here. Now, right here is for your lower trap, right? You're almost in the same position for serratus. You've got about 20 or so degrees of flexion, coupled with about 120 degrees of abduction. And I'm going to have my stabilizing hand lightly over her scapula. When I do the test, I'm feeling for the scapulars like they're up. And that's good. Your scapula doesn't move. I can just feel the muscles. And that's what it's supposed to do. And that one's good. Does it hurt? Yeah. So there's something there, but it's actually functioning pretty. Now here's going to be, so we test the serratus ideally here, but then we'll come down halfway. And there we find it. So there's different divisions. And then right here, yeah, so that's what it is. So here you're good. Now those five, and I can feel her scapular wings right from here. Let's try that on this side. Yeah, see that stays stable all the way through. So upper division is fine here. So rhomboid could be interfering with it, but her scapula definitely springs. So here's her scapula. Right? Come down about halfway. Hold there. See that? See that? Watch my hand. Hold. Everybody see that, right? That it doesn't recover. So what happens is that it's pretty good in this position, but once we get into this position, these fibers, which are lower down here, are kicking out. They're not. So I'm going to go right in and just look for anything obvious. This is what Dr. Goodhart did. This was the birth. There. Birth of AK was the serratus anterior on a patient of his that had a chronic shoulder problem. So I'm right on, I'm doing O and I basically. Sure I'm not on that. Yeah, BB, it feels like a BB under raw, a slice of raw bacon. Dr. Goodhart telling that story. Told it so many times, he had it so polished. And these nodules were exquisitely tender. Sorry. Yeah. Yeah. And see how let's do this. Hold. See that? My hand's not moving. That everybody see that was a perfect example. I'm not always that fortunate where it works that straightforward. That was great. That could be from your background. So, thank you. So serratus anterior, very important muscle. Why? Because it covers such a huge area. It also has a strong myofascial fascial train relationship with the abdominal. So if you find the serratus weak and you're not finding parts of it that, like we did with Whitney, then maybe palpate on down. You might find an issue with. Then you can test the abdominal. A lot of times there's a problem. So stabilize it. If the serratus anterior isn't doing its job, all of the fine-tuned rotator cuff muscles and all the other muscles in the shoulder that anchor on the scapula don't have a stable base to work on. So it'd be like trying to do plumbing standing on a trampoline. You know, you're trying to get leverage and do stuff. And that's what it's like for all these muscles trying to do their job if the scapula isn't stable. So it's one of the most important shoulder muscles you'll learn to test. And you can fix all kinds of shoulder issues with fixing this muscle. It's right up there with psoas, axe. Indications usually like Dr. Whitney, I didn't see anything, nothing jumped out at me, but a lot of times people are doing this. They go to wave like that. And that could be other things too. It could be a frozen shoulder, it could be all kinds of things. A lot of times I ask a patient, say, raise your arm, and they go, that, well, then I know there's something going on. Now, I might take them passively, and they'll be fine. But I know it has something to do with it. Their muscles are firing. Anyway, it's very important. So you guys are going to master this by the end of this. It affects breathing, like the abdominals do. It's such a broad area. It's related to the lung, too. The lung-related muscle meridian relationship as well as that organ. With Dr. Rob testing it, seated, you can test it seated. I'll test them supine sometimes. But however you test them, make sure you test them the same way throughout your treatment. So the lymphatic reflexes are really all along postural margins. And this time of year with people in their colds and flus and whatnot, these points, you make sure you check these points and give these a good rub in, or put your percussor on them. This really helps with lymph drainage from the bronchioles in the head and neck. So it's innervated by the neck. So neck problems, especially lower neck subluxations, fixations, often will be the reason why this muscle isn't fine. We didn't check that either. Just went straight to the muscle and got left. There's the, okay, I have some extra slides so we can review the advantage points. So this is the point over the right lung, the soft spot when we're little. And this is the Bennett reflex for a whole bunch of muscles. Yeah, so serratus, coracodeltoids, all related to lung, right? Diaphragm related to the governing vessel, levator related to lung, supraspinatus related to the brain, subscapularis related. So always remember, this point is lung, heart, brain related. Also, that's the good. And then up here, of course, you've got a whole bunch of muscles. These are our emotional ones that we use for NT and things like that. Those are also the Bennett points for all the bladder and stomach related. These are for your own use. You can use these slides, you know, them off, whatever, and use them later. They can turn. they can, if you're having trouble getting a muscle, say you've done all the stuff and the muscle is, the muscle keeps coming back, then this is a lot of times when you check these. Or if you have a reason to, if you did a bunch of cranial work and found a lot of cranial falls, then a lot of times these points have been disrupted. So you might want to.
Do you tap them?
I just have a patient TL them, or I might TL them. How to treat the bad points. You hold light pressure over them. Like they say, no more pressure than you would put on your eyeball. And then you just feel, and a lot of times you have to tug around and you'll start to feel the pulsation. Sometimes if you feel the pulsation in your own fingertips, and that's cool too. But at some point you'll be able to differentiate the pulsations at those points. And a lot of times they won't pulsate for a while and then they got it. What you've done is you've awakened a pathway that gets the brain to pay attention to that particular vascular pathway. So lung nutrition, RNA, I don't know, you know. Dr. Francis used to use a lot of RNA. RNA can be really good for like, people are chronically switched, check them for RNA. Neck extensors, well, we got you up here, let's, neck extensors. Actually, so we're testing a whole group of muscles, as you can see, and they go clear down to T6. So if your patients are sitting in chairs all day working, their heads kind of cantered forward, those muscles come clear down into the mid-thoracics, where they're really. So a lot of times they're thoracic problems. So come straight back this way. Put my arm in front of her, broadly across her collarbones. You see where my elbow is? And I push straight forward, and that's strong. And that's just neck extension as a group, and then strong. Yeah, there's something going on. So touch your back. Yeah, so she's got an SI thing going on. And then, because well, I'm not there yet. I'm not there yet. Who knows? Yeah, so neck as a group, in extension, right rotation, and left rotation. So that's how we're testing, as you can see, a number of muscles. Now, go back to fixations. When a neck extensor on one side weakens, it's going to be we'll say, or it's going to be the iliacus. Or I'm sorry, the ilium on that side. It's going to be the SI joint. It's going to be the fixation. So that's what we found here. And when I test it now with her TLing that left SI, she doesn't even have to induce motion, but she could. That turns on. But without the TL, let's go. So the classic thing with neck extensors is this. Basically, and usually if you see this, a lot of times you see weak middle traps, lower traps. So all the postural support muscles are hypotonic. So the deeper, smaller intrinsic muscles are doing all the work holding this up, and they get really tight. And all the tympani and the sacros, all the small, what they call it, sacrospinalis muscles, one that go sacrum up, and then what are the ones I'm thinking? The semispinalis, the ones that go from TP to SP. Rectus spina as a group. So these muscles work as a group synergistically, and then they'll work at times right and left. They'll work antagonistically. So any kind of neck issues, any kind of upper extremity issues, these are anything to do with the neck. You want to test these muscles. You want to test the neck flexors, and you want to test the neck extensors and the upper traps. And let's test your scalene. So right scalene. Yeah, so right scalene is a little weak. And then left extensors. So there's something going on. GL there, because that shows. Yeah, so that's related to the probably maybe you got to look back to there. And you already know that.
What I can't.
Yeah.
Or is it this?
Dr. Rob is testing the neck extensors from very effective, but be really careful. If the patient's weak, if they let go, they can face, of course. So you make sure you've got your hand here in case, and make sure you bring them into this position so that they, otherwise you're going to, the cerebellum is going to think that the neck wants to go forward. This way it turns on the tone so the body will make an effort. Otherwise, the body will not try to extend the neck. I learned that from Dr. Wally years ago. When you have somebody prone, you want to have them do things like activate certain extensor muscles. Otherwise, you can get some false positives. So you can test, say, unilateral group, air supply, neck, middle to lower neck. Chapel reflexes are first in the costal space. You've got K27 right here, 3 inches out, right along that collar. Underneath it. Then right at suboccipital. There's the vascular reflex, and the cranial stress receptor down on the opposite. So, stomach-related nutrition. 6, 3, iodine. I'm a big fan of iodine. It's really been life-changing. There's a little side note here. If you've got chronic stuffy nose, try iodine. Try testing the patients on that. If you've got stuffy, like you can't blow it out, that's why I said that one. If you've got chronic runny nose, test lip and biofilm. If you've got stuffy, can't move anything out of your sinuses, test for iodine. Okay, poplitees. So I did this earlier this morning. Okay, good. So the same, you start out like you're going to test the hamstring. Then you anchor the heel, you rotate the foot, and of course the tibia. You really want the tibia rotated. Get as broad a contact as you can. I use my forearm against her foot. I got my hands above your talus level, both. And then I just twist. That's weak. Now, if the foot's weak, this might move, but you gotta determine if this is moving. And I look right there, and I can kind of feel that that's. Feel it moving here. And that one doesn't. That one. So, left one, and Popliteus is never going to be the only problem. It's going to be, if you have a weak Popliteus, you better check over there. I tested there last session. $100 the first person.
Sartorius.
Now,
A lot of people say it.
Sartorius, yes. And then what's this one?
Chrysalis.
Chrysalis, thank you. So, check your notes. Oh, baby. About that, yeah. Big time, big time. So, everything turns on with third grade. That tells us something, right? But is the Popliteus an adrenal-related muscle? What's it related to? Gallbladder. I know. I can do that. No difference. Go to the liver channel. Back to the adrenal. Yeah, big time. Yeah. You know what we need for that. Okay, so Popliteus. Action, it internally rotates the tibia. Very important muscle for maintaining that third motion of the knee, the internal rotation of the tibia relative. It will turn off a lot of times with traumatic knee injury. It'll kind of not remember how to fire properly. That's what we really. So stabilization, I get as broad a contact as I can on that lower leg. Popliteus, same Chapman as the liver, right? Only Bennett point is going to be there with the stomach and the bladder. No, that's right. No, it's the rhomboid is there. The no, it's the meat. That's right. It's the only Bennett point that's not on the head. That's right. It's the medial knee. Nutrition. A lot of times, what's going on with bile flow is what's going on with the stomach. Stomach acid dysfunction. You don't get proper pH dynamics in the upper duodenum. You get poor gallbladder triggering, gallbladder contraction triggering. Honestly, making sure the stomach is putting out the right amount of acid, and making sure that the liver has what it needs for, especially things too, which is the B extracts, containing things like taurine. Raw beet is a little bit of taurine. Phosphatidylcholine. Teres major. Okay. C5-6. It's not a rotator cuff muscle, but it's right next to the rotator. You get teres minor, which is a rotator. This one is an internal rotator and extender. And want to bring them into full, give that muscle a chance to be in full contraction. Or you would do both. Just do one. And so I've got her stabilized here. Push this way forward. It's pretty good. Side. now let's do both. And the weak bilaterals, and that's one of the things for addressing. So yeah, yes. Could somebody grab me this? Somebody grab me a couple of Adreno things, just the usual size IED, ADB5, ADHS. Do you have standard there too?
Standard still the other.
Oh, okay. Just grab me, I just really quick one to do. Look at that. Major, you can see it attaches way below the cup. It aids the lat in internal rotation. And the organ it's related to strangely is the spine. And it's on the governing list. Okay, so go into that and submit. So that doesn't do anything. Okay, so just move that in. That's amazing. Huh? Which one? ADB5. Yeah. So of the three, we have ADB5, which is kind of a stronger glandular, and then ADP. Oh, ADP, interesting. The ADHS, which is a non-glandular, more adaptogenic. They're probably okay. They just need a little. So now, so any shoulder problem is an indication to check this muscle. So, there'll be pain in the back of the shoulder. It'll kind of sometimes hard to trace. A lot of times these muscles need get injured a lot. They're not really big. There's Dr. Robbie's testing. That picture is so dark. He's testing all the things. Yeah, he's just doing one. Teres major, 2 inches out from the sternum, second hip. Really close to the teres minor and the subscapularis chapel. And it's close to K27. It's a very busy area. Stress receptor is interesting because this is a commonly injured area with head injuries. That's bites, facial injuries. Lots of people find sutural. We'll learn about checking for sutural cranial faults. That's about it. So, brain food, zinc, kelp, iodine, magnesium. Just adductors. Should we just do those? I think that's all of them, right? Adductors. Now, there's a cheap way to do adductors, which I do all the time because it's easy, and you'll pick up most of them. That's pretty good. Then there's the more expensive way. And this is and you can test these with glutamine. Remember glutamine first session, bench your knee. Glutamine, we stabilize, make sure they're perfectly, and that's really good. Now, while we're there, take this leg out. I'm going to bring it up this way. I'm going to hold this leg this way, have you hold there.
I can't tell my.
Right again. Yeah, no, now see, it tested fairly strong, it's fine. On the other side. This is like,
Hard work.
this is like Glute Max, a lot of times it'll kind of screen, not too bad, testing is fine. First, yeah. But once again, it's renal. Yeah. So that's affecting that. Yeah. So her adrenal Chapman's actually facilitated.
That's the test you have to do.
That's the test you need to know.
The actual.
Yeah. I mean, no,
I never learned about
that way?
it. Yeah.
You never learned that?
No, not until Hank said this is how you have to do it.
Oh,
It
yeah.
just made it up. Like, never seen that in my life.
Oh, really?
Yeah.
You never learned that back home? That's strange. Because that's a really, I mean, a weak adductor cannot hide from you. Same with a glute med. A weak glute med, if you do it, if you test it on the side, it's going to show if it's weak. So the adductor is a large groove, very important muscles. They often develop really chronic trigger points. They often have O&I issues, and you can see how extensive the origin insertions, especially insertions, are looking through. And that all can potentially develop little microforms. It's related to the pericardium. There's three names there: circulation, sex, heart protector, heart constrictor, probably a few other. Like the abductors, so you got adductors, abductors, hip extensors, hip rotators, pelvic knee stabilizers, and the sartorius, all related to environment and all related to pericardium. So anything endocrine can affect anything. It's like we're saying your adrenals apparently. It's affecting a number of us, including the populations. So there's some other pictures. I like these pictures out of this particular app. Because this is kind of cool. You can kind of see how they anchor up here on the pelvic bone. You can see where the iliacus is there. There's the psoas coming down. There's a more graphic picture of them. Now, you can break these down. For this class, you don't have to, but if I'm doing this in the real world, late on. So I might bring these up and I'll have you hold there and I'll test at a very adduct. See, that's not too bad. I would come down a little bit, hold there, and that's what we do. That's not even terrible. I'll come down a little bit more. There, that's weaker. Now we can come up with a little more flexion, and then we can back this way. So if you're testing someone with a, so there's several different positions there that are really weak, and several that are pretty good. So, but just testing it straight on, sometimes you'll miss. Yeah, see that tests weak, but as a group, but there's individual ones that are weak. Thank you for that.
I have a question. Something that I've heard here in school is that with adrenals, we tend to be hypertonic or tend to not hold adjustments. How is that?
Yeah, that's true. It's a ligament stretch syndrome.
Okay.
Yeah, it's a real thing. We talked about that last session. Maybe I just touched on it.
For one of the first sessions, we definitely talked about it.
That's where you do a quick stretch and it will globally weaken the patient. Yeah, but yeah, it's a thing. And so these are the people
Which
you
is
don't,
most likely what all my stuff's on.
I mean,
I feel like everyone in school too tends to be hyper flexible.
Yeah.
what's interesting to me about this, that's strong and clear, let's just give you a little stretch like that. Do that. And you can do that with any muscle. So if I start yanking on her and adjusting her real hard, you might get stuff to move, but it may be more stressful to her body.
Like really tired after.
Yeah, and what's interesting to me though about that, because it supposedly has to do with the levels of adrenaline that are released when there's too much epinephrine going on, but it will change in real time. If you make corrections and if there's cranials involved, a lot of times I'll see the ligament stretch reaction disappear. After
You're
a
taking stress off the system.
we are, but you wouldn't think it would change the physiology that quick. That's the thing that puzzles me. There's something else.
Well, I think that maybe you're resetting the physiology for it to be in a more parasympathetic state, not like you're changing the muscle quickly, so you're heading in the right direction. That obviously wouldn't change the current something heal.
That makes sense. Yeah. Makes sense. There's something going on.
Because if you could take that away in 1 minute, that would be.
Thing is, it usually comes back if you don't get it. But it's just amazing to me. You'd think it'd be something that would take weeks to turn on.
But you have to be on adrenal.
Yeah, for sure.
So that would be. You don't remove the stressor, be graduating, and then being a doctor for a while, and then retiring. Maybe your adrenal will recover when you retire.
So, very important muscles. There, and a lot of times when you see people with, there's the classic stance. You know, I mean, you don't even have to test there. But then you also will see adductor issues with this stance. And there's a common thing I see with older men where they start to, and I think it's related to their testosterone level. And they start to lose muscle mass. And a lot of times they'll lose more muscle mass in their abductors, and their adductors will get overpowered and they'll end up with this kind of stance. You see that? I see that a lot. It's like they have less muscle, but the muscle they do have is just holding on. And it ends up, literally, it'll make them more of both. And usually there's knee arthritis involved. I see that pattern a lot. And it's, when I see it. Anyway, very important muscles for pelvic stability, gait, knee stability. Basically, every time we take a step, the adductors, these adductors actually have to contract a certain amount to keep us in line. And then as we switch into the opposite leg swing, the abductors have to contract and these muscles have to inhibit. So there's a lot going on with hiking and walking and running with the adductors and the abductors. So it's huge. And so not only do they have to eccentrically contract and deal with a lot of forces, they have to be able to concentrically contract in a split second as well. So there's a lot going on, and there's a lot of opportunity for disruption. And we get focused on some of the outer, we don't always get into the adductors. A lot of, if you look at the trigger point, so it's lumbar and all the way down into sacrum innervation. So any kind of subluxation in lumbars or pelvis can cause this. You look at trigger point charts, and there's a lot of weird trigger points in this area can mimic a lot of knee pain and hip pain. Okay, the weird thing about the Chapmans is they're located behind the rest. So they're a little bit awkward to treat. You can have your patient kind of hold that man at Orwood, and then you can kind of give a their hand.
So you're moving that.
Yeah, you got to get the height. It's right, and and it's pretty, can be right on the pretty tender. And then, of course, at the tip, inferior tip of the occiput, once again, cranial issues can tie in with this. There's some, these are all biotics products that then, okay, pectoralis minor. That's it. Okay, pectoralis minor, last one, I promise. We'll take a little break and then we'll workshop these and then we'll get. Okay, pec minor is one of the muscles that often gets overlooked in the shoulder. It does not attach to the humerus. It goes from the ribs to the coracoid process. So it does this. It doesn't do this. It does this. So I call it, white man dancing muscle. I remember when I was back in high school, and the guys would get up and they kind of dance. They didn't know how to dance. They didn't really want to dance, but they kind of had to. I was one of them. So you kind of do this, You don't want to, give up any, make yourself vulnerable. That kind of thing. But it's the muscle that protrudes the shoulder. So if you're reaching forward like that, it's protruding, but then it's also stabilizing. So if you're doing push-ups or anything like that, pushing out, the pecs are doing the big movement. The pec minor, the pec majors, but the pec minors are keeping the scapula from going back this way. So a lot of brachial plexus issues I find with that's pec major clavicular, pec major sternal. So pec minor is you bring the arm across, make sure they're protruding and have them hold right about there. Then you come over this way, and you can see both. There, and I put my hand here because I want to feel for what's moving and feel it. See, that one's good. Try this one again. Yeah, so that was not good. So hers is weak on the right. Now the majors, stay. Did. So touch your chat. Actually, this is good. So go to the muscle, right? It comes off the ribs there. Difference. Come up to the. Yeah. So right at the insertion, there's something going on. Now, you guys remember your anatomy. There's another muscle that attaches to this. Do you remember what it is? Shoulder muscle, lung-related muscle.
Correct.
Yes. We haven't run this one yet, but that one, yeah, that one seems fine. So I'm right on this, right there. I'm just going to do a little O and I. And now let it stretch. And, oh, no. So it's not liking the stretch. So what would that indicate? Hypertonic. And what would the pec minor be antagonistic with that we learned last session? Rumble. Rhomboid, remember rhomboid, rhomboideus. That's better. Now touch your chat. So, I'm gonna get right on her. Chapman reflex is right on the of the breathe. I'll usually use my percussor on that with a round head. There, yeah. Stretch and gain. That just, we did one on. We did insertion and the chapter. So, now, the reason pec minor is so interesting is that it can affect the lymphatic return through the thoracic cavity. And of course, it can affect the lymphatic drainage from the head. Not to mention what it can do. It can really mess with the shoulder. So there it is, not real big. A lot of times people come in, they think they hurt their ribs, and they did. But a lot of times where they hurt the ribs is right where these fibers tie in. Sometimes O and I can help if they can tolerate it. Breathing, deep. A lot of times, weird paresthesias that are affecting the arm and hand might be that. Some of the trigger points will refer into weird places. Where this has the alternative test. The classic test is, see if we have it. Classic test, if you look at Walter, patient is, go ahead and lay the back. The patient is on their back, and he has them just lift up like that and just push down. Now, that's, you kind of are. It's not really a great test. There's another one where you kind of go this way, make this, and you know, honestly, but this one here seems to be the best. You make sure you bring that into position. Make sure they hold it like that, and then as I'm pushing this way. And she was it strong thing. So that's that. But see, the other way of testing it didn't really. Yeah, and see this way of testing it. Yeah, I mean, I would say that's one. But it's, so that this is by far a better test. This is the best test, just like the adductor on the lights sideline is a better test. Okay, so should we try those? Take a little break, just stretch your legs a little bit, and then we'll
Still out of shape.
oh man. Forgot. I missed my granddaughter's first basketball game.
Oh.
They
Did they
tied 14-14.
How old is she?
She's 9.